In this video, we will discuss the interpretation of ECG in various congenital heart diseases. I would recommend to watch the previous video of ECG interpretation in various congenital heart disease, part 1, before watching this video for better understanding. Let's start with the features that has to be noted in the ECG. We should look for the QRS axis, the looping of the heart, the transition of R wave, and the strain pattern of the ventricles. When you understand these features, one can diagnose the congenital heart disease with an ECG. Let's explain each feature one by one. QRS axis. It can be either right axis deviation or left axis deviation. To calculate axis, we have to look at the QRS complexes in the lead 1 and AVF. Let's plot the net QRS amplitude in the hexaxial reference system. In lead 1, the R wave amplitude is 5 small boxes. That is, it is positive 0.5 millivolt. The amplitude of the negative S wave in lead 1 is 6 small boxes. So the net amplitude is plus 0.5 millivolt minus 0.6 millivolt. That is minus 0.1 millivolt. Let's plot it in the hexaxial reference diagram. In lead AVF, the R wave amplitude is positive 0.5 millivolt and there is no S wave. So the net amplitude of QRS complex in lead AVF is plus 0.5 millivolt. Let's plot in the diagram. Draw two perpendicular lines from these points. The line where they meet is the QRS axis. Here it is more than 90 degrees. So there is right axis deviation. For the left axis deviation, the net QRS amplitude in lead 1 will be positive and the net QRS amplitude of the AVF will be negative. So when we plot in the hexaxial system, it comes less than minus 30 degrees. Looping of the heart. It can be either clockwise looping or counterclockwise looping. If the Q waves are present in lead 2, 3 and AVF, it is called clockwise looping. If the Q waves are present in lead 1 and AVL, it is called counterclockwise looping. Transition of the R wave. In normal ECG, the amplitude of R wave steadily increases from V1 to V6 and the amplitude of S wave gradually decreases from V1 to V6. At some point, around V3 or V4, the QRS complex changes from predominantly negative S wave to positive R wave. This is known as the transition zone. If the transition is seen as early as V2, it is called early transition. And if the transition is seen at V4 or V5, it is called delayed transition. Strain pattern of the ventricle. Right ventricle strain pattern shows tall R wave in V1, that is more than 7 mm, and ST depression and T wave inversion in V1 to V4. Left ventricular strain pattern is seen as ST depression and T wave inversion in the lateral leads V5 to V6. If there are absent Q waves and RS wave pattern in lead V5 and V6, that means the left ventricle is underfilled. So now let's analyze this ECG. This ECG shows right axis deviation and features of right ventricular hypertrophy, that is dominant R wave in V1, that is more than 7 mm tall. There is early and abrupt transition to RS pattern in V2. It is due to the window effect of VSD. The LV forces are seen in the right precordial leads. There are Q waves in lead 2, 3 in AVF, so there is clockwise looping. And there is absent Q wave and RS pattern. This denotes the LV is underfilled due to decreased pulmonary artery blood flow. All these findings lead to the diagnosis of tetralogy of Fallot. In case of palliative shunts or development of collaterals, there is Q waves and tall R waves in V5 and V6, denoting there is adequate or increased pulmonary artery blood flow and there is adequate left ventricular filling. If right axis deviation is more than that of TOF, that is more than 150 degree, it can be either double outlet right ventricle or D transposition of great arteries. In DORV, there is right axis deviation more than 150 degree with right ventricular strain pattern. But when you see the looping, it is counterclockwise looping in DORV, whereas it is clockwise looping in TOF. When there is late transition of R wave with right ventricular strain pattern, that is ST depression and T wave inversion in V1 to V3, it denotes the RV pressure is suprasystemic. RV pressure can become only suprasystemic when there is absence of a VSD. So it is a case of severe pulmonary stenosis with intact ventricular septum. In this ECG, the axis is left axis deviation. There is counterclockwise looping and there is RV strain pattern. These findings are consistent with atrioventricular septal defect. In this ECG, there is left axis deviation. There is counterclockwise looping as the previous ECG, but there are no RV forces. There is only LV strain pattern. These findings are consistent with tricuspid atresia. Lastly, if there is all positive or all negative complexes from V1 to V6, it is called stereotype complexes. When it is present, it denotes univentricular heart. Or when there is right ventricular hypertrophy with left axis deviation, or left ventricular hypertrophy with right axis deviation, then also it denotes univentricular heart. Let's complete this video here. Hope it was useful. See you soon in the next video.